In this particular section, we are going to see on the flow volume loops. At the same time, we are also going to see certain other important function tests like 6-minute walking test, your DLCO, and probably we can finally finish off with the algorithm that is going to be the master chart for your analysis of PFT. Anyways, fine. So what is a flow volume loop? A flow volume loop is one thing where your volume in PFT is actually plotted against the flow. Let us see how to plot that. So again, stay with me and draw with me. So let us see how a flow volume loop is going to look like. Okay, so let me draw this. So here, what I'm trying to do is, I'm going to plot the volume against the flow. Remember, not the time or volume. Here, it will be timed as well. So don't think the flow volume loop is not timed. Typically, these flow volume loops are timed. The curve what I discussed is only for the basic understanding, but this flow volume loops are also actually timed, so it's not a big deal. So what is the normal flow volume loop you are going to get? The normal flow volume loop what you are going to get should be something like this. This is the typical shape of the curve that you are going to get. Clear? So if somebody asks you what is the normal shape of the curve, I'll be calling this shape of the curve as something called a joker's hat or a clown's hat appearance. So this is the normal shape of the curve. Clear? The normal shape of the curve is a joker's hat or a clown's hat. So what are things that I'm going to plot? So this is the volume. I can see in the flow volume loop, it's always from the point of maximal acceleration to the point of maximum inhalation, from the point of maximum acceleration to the point of maximum inhalation. So which means it is not like you're going to get only one curve, you're going to get many similar curves like this. Like for example, let me draw separately. For example, you will get many similar curves like this. So which means you're going to form multiple curves like this, so series of breaths you're going to give in a flow volume loop. So you're going to form a series of lot of curves. I'm showing one curve as an example like that. Okay, the normal appearance is going to be the joker's hat or the clown's hat appearance. So since this is the flow, and remember always this is the expiratory limb and this is the inspiratory limb. So that is really important. Remember, and again this is a forced expiration and this is also a forced inspiration. So this is a forced expiration and it's a forced inspiration. All the things what you do in a flow volume loop is forced. And you can also see there are other indices that are important in a flow volume loop. The most important being this particular volume, which is from the time of, you can see this is one cycle that starts from inspiration to, this is an expiratory cycle. Let us draw like this. This is an expiratory cycle. It ends in the completed expiration. And you are going to have an inspiratory cycle. Once again, you will get an expiratory cycle. And once again, you are going to get an inspiratory cycle. So expiration, inspiration, expiration, inspiration. You are going to get multiple curves like that. So which means the volume from which you have maximum inspiration to maximal expiratory point or expiratory to inspiratory point, obviously this must be the FVC, the forced vital capacity. And typically you can see one important thing here, the peak flow that are achieving through this flow volume loops will be called as something called a PEFR. That's called a peak expiratory flow rate. Very important thing again. This is called a peak expiratory flow rate. Clear? And next thing, in that FVC itself, because this flow volume loop is timed, I can find out, for example, this volume might be probably, I'm not telling always, this volume might be your FEV1 also. You can find out the tidal volume, you can find out everything through the flow volume loops. It's not like you cannot find out only the FVC and all these things. So you can find out anything in the flow volume loop. And one more interesting thing you can see is this, you can take it as 25% of the FVC. This contributes to 25% of the forced vital capacity of the total. And you can see the corresponding flow here. So this is the corresponding flow. This is called forced expiratory flow at 25% of FVC. Similarly, you can get this is the 50% of FVC and this is something equivalent to the 75% of FVC. So let me plot the graph. So I am going to get this is the forced expiratory flow at 50% of FVC, which means I can call it as FEF 50. Similarly, I can get another value called FEF 75 like that. So what I am trying to get is I am plotting the flow rates at 25%, 50% and 75% of the FVC, and I am getting the corresponding flow rates in the y-axis. Clear? So this average, so I am getting three values here. I am going to get an average of these three values is what I am going to call it as something called FEF 25 to 75. This FEF 25 to 75 is also referred to as something called a MMEF, otherwise referred to as something called a maximal mid expiratory flow rate. So what are the volumes I got here? What are the value? Things I'm going to look out for. So whenever you see a flow volume loop, the first thing see for the shape of the flow volume loop. Point number 1. Second thing, look on the FVC and FEV1 on the flow volume loop. Number 3, look on the PEFR, peak expiratory flow rate on the flow volume loop. Number 4, also look on the maximal mid expiratory flow rate, that is FEF 25 to 75 on the flow volume loop. Clear? Using this FEC and FEV1, you can also find out the Tiffany index also. This also can be found out through the flow volume loop. Clear? So a lot of things you can assess through the flow volume loop, but these are the major things that I need in a flow volume loop. But remember, even in a flow volume loop, as I told you, you cannot find out the residual volume, and the associated capacities also you cannot find out, which means to find out all this you need special techniques like helium dilution or body box. So without that you cannot find out the like your residual volume and the associated capacities even through the flow volume loop. For example, if you ask where the residual volume is, I can tell somewhere it's an arbitrary lines. Here is where the residual volume is, but I have no idea. So it's somewhere here, but I don't know the exact volume. You cannot find out through the flow volume loop. Clear? So we have already found out the importance of FEC and FEV1. We are going to yet to find out the importance of the shape of the curve. We are going to find out. But what is the importance of this PEFR and MMEF, maximum mid expiratory flow rate? Remember, the importance of PEFR and especially the importance of this part of the curve. For example, let us assume this particular region of the curve, till you attain this PEFR, peak expiratory flow rate, is completely something called as effort dependent part of the curve. This is actually referred to as something called effort dependent part of the curve, which means to reach the PEFR, you need a good effort from the patient. If you don't have a good effort from the patient, it is impossible to reach a good, smooth initial portion of the expiratory curve. Clear? At the same time, this portion of the curve, you can call it as something called effort independent portion of the curve. Clear? So this portion, if you call in the flow volume loop, I can call this FEF 25 to 75 region. This is typically referred to as something called a effort independent region. This is an effort independent region, which means typically this region, in this particular region of from this FEF 25 to 75 region, what typically happens is the air moves through the smaller airways. Air movement is from the smaller airways. So, this portion of air movement that is happening through the smaller airways is not dependent on the effort. At the same time, this MMEF, that maximal mid expiratory flow rate, that FEF 25 to 75, one is importance is effort independent, so it's not going to be associated with any part of effort. So even if you give effort or if you don't give effort, that is going to be smooth. And second thing, since it is indicative of air movement through the smaller airways, it is been thought, I'm not telling it is right now, this is the idea, it has been vaguely thought in the previous few years back that this can represent one of the early signs. If MMEF is decreased, it can indicate one of the early signs of small airways disease. Small airways disease. Clear not? So this, but remember, this has been disproved by many trials. It is not indicative of small airways disease. But anyway, for at least for exam purpose, you have to know that this MMEF decline might indicate and might be the one of the very sensitive indicators for detecting small airways disease. But even though current studies have clearly disproved them, but anyway, for at least for exam sake, you have to know the importance of this MMEF. What is the importance of this? Two things. It is effort independent part, whereas PFR is definitely an effort dependent portion. But whereas the other limb of the curve, FEF 25 to 75 region typically is the effort independent part. At the same time, that FEF 25 to 75 region, if it's declined, it is one of the very, very sensitive indicators for small airways disease. Very important point. So these are the things you are going to assess in the flow volume loop. So 4 things: shape, FE1 by FE1, FEC and FE1, and the Definue index you are going to see, and you're going to see the PEFR, peak expiratory flow rate, and finally you are going to find out the MMEF, that is the maximal mid expiratory flow rate. Clear? So with this, we can go on to the different diseases causing different flow volume loops. I mean different kinds of flow volume loops. Let us see first a typical obstructive flow volume loop. What will happen in obstructive lung disease? So let us put one common thing and we can duplicate it multiple times. So let us put the dotted lines as an indicator of a normal flow volume loop, how it's going to behave. So these dotted lines are going to be your normal flow volume loop. To understand in the baseline, this is a baseline normal flow volume loop. So let us duplicate this. Clear? So let us see. So what are the different conditions that you are going to have a different kinds of flow volume loop? So the normal flow volume loop I told you already. So let us assume in typical mild obstructive lung disease, what happens in a mild obstructive lung disease? In a mild obstructive lung disease, typically you are going to get a curve something like this. This is what you are going to get in a mild obstructive lung disease. So what does the curve depict? First thing, I told you to look at the shape of the curve. Here in a mild obstructive lung disease, the shape of the curve, you are seeing a typical scalloping is what you are seeing. Otherwise, this is also referred to as something called coving in this area of the curve. So this is a typical finding of an obstructive lung disease. Scalloping or coving in the, like in the effort independent portion of the expiratory limb is very, very typical of a obstructive lung disease. And you can see second finding that your peak expiratory flow rate is actually decreased. It's a very common finding. It can happen in restrictive lung disease also, but anyways, let us see now. PFR is actually reduced. And you can see one important thing, that FVC is almost near normal, or it can be mild reduction FVC can be there. But it's almost near normal in a mild obstructive lung disease. Clear? So what are the findings we'll be seeing in other things? So FE1 will be dramatically decreased for sure. FEC is relatively normal or only mild decrease will be there. Whereas your FE1 by FEC ratio is going to be decreased for sure. It is going to be less than 0.7%. So what about the other factors? Other things, if you want to extra add, you cannot find it by flow volumes, but if you want to add extra, your residual volume may have a mild increase may be there because of air trapping. At the same time, your TLC may have a mild increase because of hyperinflation. Clear? Remember, TLC increase is what we refer to as something called hyperinflation, and your residual volume increase is what we refer to as something called air trapping. So both are different entities that you have to understand. Clear? So these are the findings of a mild obstructive lung disease. The classical example, if somebody asks you where you are going to encounter this mild obstructive lung disease, is a typical example in an acute asthmatic attack. Very, very classic acute asthma. That's where you are going to find this kind of PFT. So what is going to happen in a severe obstructive lung disease? Now let us move on to the second condition called severe obstructive lung disease. Let us put the curve. So here you are going to see the curve something like this. So this is the curve of a severe obstructive lung disease. What you are typically seeing is severe scalloping of the effort independent portion. Number one, the shape of the curve, what you are seeing is severe scalloping of the effort independent portion. Next thing what you are seeing is again there is a drastic drop in the PEFR. I mean that is expected. As expected, you are having a drastic drop in the PEFR. And what is happening to the FVC here is decreased. Actually FVC is also decreased here. So why the FVC is reduced in severe obstructive lung disease? That is because of the severe air trapping. I'll tell you one important point on this. You might not be understanding this. This FVC decrease in a severe obstructive lung disease is also referred to as something called pseudo restriction. Why you call it as actually pseudo restriction is because actually it is not the restriction of the lung because of some underlying restrictive lung disease. It's because the air trapping itself restricts the lung. So how air trapping can restrict the lung? For example, my lung is severely hyperinflated. My lung is this much already. Air is not coming out also. Air cannot move in also. So what do you mean by FVC? FVC is the maximum amount of air that can go in and the maximum amount of air that can come out. Any one. So you can call it as FVC. So from the point of maximum inhalation, how much air that can come out maximally is what is going to call it as forced vital capacity. Suppose I am telling the fact that if my chest is severely hyperinflated due to severe obstructive lung disease, how much air I can inhale now? Very little. How much I can exhale? Again, very little. So this air that is trapped in the lungs itself preventing the movement of the air in and out is what we refer to as something called a pseudo restriction. And typical example where it happens, where you get the pseudo restriction is emphysema. Especially in severe emphysema cases, you will encounter this typical pseudo restriction where FVC may be well and good, it might be low. Very important point to understand. The next thing what you want to know is what will be the FEV1? Definitely it will be decreased so much. There is no doubt about that. FEV1 will be decreased so much. And if you take the FEV1 by FVC ratio, definitely it will be less than 0.7. It will be decreased. There is no doubt because it's an obstructive lung disease. But your FVC decrease is the one that is going to give rise to the confusion of pseudo restriction. But I will tell you. Clear? And remember, these kind of curves can also be seen. One of the important differential diagnosis for this curve. Suppose if you are finding this curve, something like this, where FVC is decreased and you are seeing a severe scalloping like this, you could be asking me one question, sir, why can't it be a mixed obstructive lung disease and restrictive lung disease? Where because of the restrictive lung disease, I am having FVC reduction alright. Because of obstructive lung disease, I am having severe reduction in FEV1. At the same time, my Tiffany index is also less than 0.7 because I am having a obstructive lung disease in this patient. So why can't it's possible? Yes, what you are asking is right, it is possible. So how to differentiate between these two? There is no way to differentiate this kind of curves. I mean, history is very important. Appearance of the patient also will tell you. But anyways, the best way to differentiate this curve from diagnosing whether it's a severe OLD or a mixed OLD versus RLD is by putting them in a body box. Putting them in a body box, that is body plethysmography, and I'm going to find out the TLC. If TLC is increased, that is more than 80%, I'm going to go towards a severe obstructive lung disease. If TLC is decreased, that is if it's less than 80% TLC, then I'm going to call this as a mixed obstructive lung disease and restrictive lung disease. This is very important, which means the same kind of curve, you can get in both kind of patients, either in a severe OLD with pseudo restriction, or you can get also in patients with mixed obstructive lung disease and restrictive lung disease. These patients also will behave the same parameters. So how will you differentiate? By putting them in a body box and find out the total lung capacity. The total lung capacity is very low. You can tell it's a mixed OLD versus mixed OLD and RLD. Whereas if the total lung capacity is increased, suggestive of hyperinflation, you can tell it's a patient with a severe OLD with pseudo restriction. Simple. That's all. Now moving on to the next set of flow volume loops. Let us see what will happen in RLD. So what's going to happen in RLD is something This is what you're going to see. This is a typical curve of an RLD. I mean, you might ask me, sir, why you are starting from here, not from the zero? No, not like that. Just to show you one important fact. It's not like you can start from here also. I mean, there is nothing to tell that you have to start from there or start from here. It's all about the curves because you're going to get multiple curves. There is nothing like superimposed on. Just to show what is normal, I'm showing. I mean, abnormal from differentiation from normal, I'm showing all this. That's it. So this is a curve of a restrictive lung disease and typical curve of a parenchymal restrictive lung disease. What you are seeing here. So what you are seeing here is typically the shape of the curve is normal. The shape of the curve is classically normal. That's what you are seeing. The shape of the curve is classically normal, which means it doesn't have any abnormalities in the shape of the curve, but the overall size of the curve itself is reduced. The entire size of the, your curve itself is very small, suggesting the lung itself is very small. That's what it indicates, as simple. And next thing, you can see that the FVC is grossly decreased. FVC is grossly decreased. In this condition also, the PEFR is variable, but remember the PEFR may be normal or decreased. It doesn't matter. PEFR can be normal or even decreased because here the patient's effort as such, the muscle power is okay. Maybe because the volume is low, the PEFR may be a little bit decreased, but the PEFR is not important here at all. It's only important for the obstructive lung disease. It can be normal or it can be decreased. It doesn't matter here. So what will be the other features? So let us tell. The shape I told you it's normal, except for the fact that the overall size of the curve will be reduced. So now you can see that FE1 will be definitely reduced. There is no doubt. But the FVC will be decreased too much, making the fact that FE1 by FVC ratio will actually be more than 0.7. In fact, it will be more than 100% many times. It will be even high than normal. So this is a very important fact. At the same time, if you put them in a body box and find out, your TLC will be reduced, definitely under residual volume. Actually, it is variable, which I'll tell you later on why, but in exam you tell it is decreased. But actually the residual volume is variable depending on what kind of RLD you're encountering, whether you're encountering a parenchymal RLD or you're encountering an extra parenchymal RLD, depends on that. So let us discuss that later on, not now. But anyway, for time being, in an idiopathic like pulmonary fibrosis or any ILD patient, go for residual volume is decreased. That's what your understanding is. Clear? So these are the things you are going to find out. And this is the second curve of RLD. And RLD can be showing this kind of curve also. We are going to see some curve like this. So you are going to see some curve like this. What is happening here? So here, this kind of curves happen in severe parenchymal RLDs. This kind of curve happen in severe parenchymal restrictive lung disease, like severe interstitial lung disease, typical severe IPF. Some condition is going to cause this kind of curve. This curve happens because of severe reduction in the compliance of the lung. Because of that, the FVC will be so low. Because of that, the PEFR may be appearing increased. Because of that, the PEFR may be even appear to increase. That is because the curve is flattening like this, it appears more lengthened. So the PEFR will actually become, appear to increase. Actually, the FVC is so much decreased here. So this kind of curves, we typically call them as something called hamburger shaped curves, and usually a feature of a severe parenchymal interstitial lung disease, where because of severe reduction in the lung compliance, your FVC will be so low that your PEFR might appear a little bit increased. Again, this is a curve of a severe parenchymal lung disease. Clear? So the next thing, what you are going to see is a curve of maybe severe obesity. So what is a curve of a severe obesity? You will be typically seeing a mild reduction in the FVC. That's all. Nothing much. Relatively a very, very normal curve you will be seeing. So this is the curve of a very mild obesity, which means what you are seeing is shape is absolutely normal. There is no doubt. Everything will be mildly decreased. FE1 will be mildly decreased. Very mild decrease will be there. And FVC also will be showing a very mild decrease. And FE1 by FVC ratio will be typically in the normal range, which means it shows a feature of a very, very mild restriction, but this is how you see a curve of a severe obesity. Apart from that, how will you tell it is not restrictive lung disease? Because when you put them in a body box, your total lung capacity will be normal, your residual volume also will be normal. So which clearly tells you the lung doesn't have actually any problem, or there is no actual restrictive lung disease happening. Only this simple parameters will be a little bit low, and that can happen in severe obesity. Clear? Initially you might think it's a RLD, but your body box will show completely normal findings, suggesting that these patients are normal. Okay, this is a curve of a severe obesity. So now we are moving on to a whole new data on something called extrathoracic obstruction. So there are a lot of types of extrathoracic obstruction. So, but let us see some of the basics before going into complete understanding about what is extrathoracic obstruction. So whenever you take airways, let us draw. Whenever you take an airway, this is a very important basic to understand. Whenever you take an airway, so obviously it is going to be attached with the pleural surface. So always from the beginning of the basics, we are putting this pleural surface in green color. Let us stick on to the same color. So this is the pleural surface. And you know, those airways that are attached to the pleural surface are typically going to be intrathoracic airways. And those airways that are not attached to the pleural surface, that are present outside the thorax, is what we refer to as something called extrathoracic airways. And you all know that very well, the extrathoracic airways has a very, very good cartilage support, and intrathoracic airways to an extent also, they also have a very good cartilage support in the beginning, but later on the cartilage will drop. But anyways, what is the importance of this understanding this intrathoracic and extrathoracic? So let us put what will happen during expiration and what will happen during inspiration in an intrathoracic airway and an extrathoracic airway. So remember, during inspiration, what is going to happen is your airflow. Let us put maybe another diagram for understanding purpose. Let us duplicate it because I'm going to draw 2-3 diagrams. Okay, let us assume this is an intrathoracic and extrathoracic. So let us see first what happens. So air moves in during inspiration. Remember, where will be the pressure change maximum? The pressure change during maximum, the velocity of the air will be maximum in the proximal. The earlier which airway the air hits, that is where the velocity of the airway is going to be maximum. So during inspiration, the air moves through the extrathoracic airways first. Since they move through the extrathoracic airways first, the velocity of the air will be too much here. Obviously, by Bernoulli's principle, since the velocity is very high, the pressure tends to decrease. Obviously, they are supported by the cartilage, but also, but to help you understand one fact, you have to know, because this pressure drop that is happening inside the airway. So, for example, let us go inside and see. Here the pressure drop is going to happen. Because the pressure drop is going to happen, the atmospheric air tends to push inward, which means the extrathoracic airways generally tend to collapse during inspiration. They don't collapse because of the good cartilage support, but they have a tendency to collapse during inspiration because of the simple Bernoulli's theorem application. So I can tell you the fact that extrathoracic airways during inspiration tend to decrease in size during inspiration. At least have a tendency to collapse. I'm not telling it is collapsing. Similarly, what is going to happen for the intrathoracic airways? The intrathoracic airways during inspiration is going to expand. You know very well, this air is going to inflate the intrathoracic airways. Inflate the intrathoracic structures. So typically what is going to happen is this pleural space also expands. This pleural space also expands during inspiration. This expansion of the pleural surface is going to separate out the intrathoracic airways maximally, which means it's going to increase the diameter of the intrathoracic airways, which means your intrathoracic airways during inspiration tends to increase in diameter. Clear? Even though the effects are trivial in normal lung, but still, this is the idea that you have to understand. It tends to increase in diameter. But what happens during expiration? During expiration, literally speaking, the air moves out in a reverse direction like this, which means the first area where the air comes into contact during expiration. That is what the most important. That is where the velocity is going to be maximum. The first portion. During expiration, it is the intrathoracic airways. That is the place where the air, is going to first contact with the extrathoracic airways. So, which means, obviously, again, by Bernoulli's principle, velocity is going to increase here, which means pressure is going to drop here, which means these are the airways that are going to collapse, typically. At the same time, during expiration, one more principle is also happening, but the entire lung tends to collapse, which means the pleural surfaces also tend to collapse, which means these airways that are covered by the pleural surfaces tend to decrease in diameter. Clear? So, which means during expiration, the intrathoracic airways tend to decrease in diameter, whereas the opposite will happen, the extrathoracic airways tend to expand with expiration. So, what you are literally seeing is one important principle, that your intrathoracic airways tend to decrease in diameter during expiration, which means they have a natural tendency to collapse during expiration, whereas your extrathoracic airways have a natural tendency to collapse during inspiration. Clear? Your extrathoracic airways have a natural tendency to collapse during inspiration, whereas your intrathoracic airways have a natural tendency to collapse during expiration. So, that is also the main reason why whenever there is an extrathoracic large airway disease, for example, if an extrathoracic large airway disease, like for example, if you have a problem in the trachea, you are going to result in an inspiratory stridor, because the extrathoracic airways tends to collapse during inspiration. That is why the problem happens during inspiration. That's why you result in something called an inspiratory stridor. That is also the reason whenever there is a problem in the intrathoracic airways, since the airways tends to collapse during expiration, you result in problems like expiratory wheeze. That is the reason. That's the reason why the problem is going to happen during expiration. So remember, all this thing will happen only if the changes are dynamic. When the changes will be dynamic? Only in early obstruction. Only in early obstruction and early decrease in the diameter, the dynamic changes all will happen, like inspiratory, expiratory changes and all will happen. Suppose if the obstruction is severe enough, you will not see any dynamicity, which means this dynamic changes will be lost during inspiration and expiration, and you will get fixed problems, which means if the obstruction is so severe. So, for example, even if it's an extrathoracic airway or intrathoracic airway, this selectivity of seeing problems either during inspiration or expiration will be lost completely. Instead, you will be seeing problems both during inspiration and expiration. For example, in a severe fixed extrathoracic upper airway obstruction, we are going to result in both inspiratory as well as expiratory stridor. Similarly, in a very severe fixed obstruction of the intrathoracic airways, you will see wheeze in both inspiration as well as expiration. So, you are going to lose that dynamicity, means you are going to lose that periodicity in the respiration also. But in the early obstruction, still the airways are dynamically changing their diameter and trying to collapse during either one of the phases of respiration. During those times, you can get this inspiratory stridor or expiratory wheeze. But why I told you so much is you will understand in some time, because this is a typical thing that you have to know. Extrathoracic airway problems tend to happen more during inspiration, and intrathoracic airway problems tend to happen more during expiration, which is what I wanted to tell. So now what we are going to see is what will happen in a variable extrathoracic obstruction, which means it is not severe obstruction, it is still dynamic. Variable means I tell it's a dynamic but extrathoracic obstruction. So where will you get this kind of variable extrathoracic large airway obstruction? Typically you might get in squamous cell cancer of the larynx, or you might get in subglottic stenosis. Very common example is you will see in a vaginous granulomatosis. Very common question in exam. Vaginous granulomatosis causing subglottic stenosis. And you can get in vocal cord dysfunction. Vocal cord dysfunction are typically in unilateral vocal cord paralysis. Vocal cord dysfunction and unilateral vocal cord paralysis, you can get this kind of picture. I told you, the moment you call extrathoracic, still in the variable, which means the dynamic phase, typically they are going to affect the inspiratory limb. Typically they are going to affect the inspiratory limb. So which means, how can you draw is that you will be having a normal expiratory limb, but you will be getting a inspiratory flattening. You can see this is the most important area, which means what I am typically getting is the inspiratory flattening of the curve. Clear? So which means to identify this extrathoracic, especially the large airways obstruction, it is very important to see the shape of the curve. Without the shape of the curve, you cannot identify the large airways obstruction. So where most important is finding out the shape of the curve. I'll tell you why it is important in some time, but first listen and understand. So inspiratory flattening. Suppose if I am telling there is a disease called variable large airways intrathoracic obstruction. We are talking about the large airways now. Small airway obstructive lung disease is already gone. We have seen the scalloping and all these things. Now we are talking about the large airways variable intrathoracic obstruction. So which means whenever you have a large airways variable intrathoracic obstruction, if you want to tell some of the causes, you can tell causes like tracheomalacia, because trachea extends into the intrathoracic area also, or you can get in some tracheal tumors, or typically very commonly you can get in mediastinal adenopathy compressing on the one of the major bronchus or the carina, or some mediastinal tumors also, like teratoma, retrosternal goiter. A lot of things can cause this problem. Anyway, I am telling still it is a variable, which means still the dynamic is there, which means in the early stages not that severe, and large airways intrathoracic obstruction. So what is the curve that you are going to get? So you are going to get a curve something like this. So the expiratory limb will be completely okay, but there will be, inspiratory limb will be completely okay. There will be severe expiratory flattening, because the moment I call extrathoracic, I know the problem must be during expiration. So I am going to get a expiratory flattening of the curve. Expiratory flattening of the curve. Very, very important. Very, very, very important. Expiratory flattening of the curve. Clear? Now, let us assume, I will duplicate because I want to tell one more thing. I will put separately. Now, let us assume it's a fixed obstruction. It's a fixed obstruction, which means it could be either extrathoracic or it could be intrathoracic. Doesn't matter. Fixed obstruction means it's a severe obstruction. Severe large airways obstruction. We are talking about large airways, already I told you. Severe large airways obstruction, fixed obstruction, may it be intrathoracic or may it be extrathoracic, doesn't matter, the curve is going to behave in the same way. I told you the moment it becomes fixed and severe, the problem is going to be in both during inspiration and expiration, and this phasic variations during respiration all will be lost. Which means you are going to get a curve something like this. You are going to get something like this, which means there will be both inspiratory as well as expiratory flattening. You are going to get both inspiratory as well as expiratory flattening. This is very, very, very important to understand, because your dynamicity is lost and the phasic changes in the respiration is lost, and you are going to get the flattening of the curves in both inspiration as well as expiration. Again, very, very, very important point. So what are the conditions that can cause fixed obstruction? Very commonly, it can be caused by a very large tumor, either in the intrathoracic or extrathoracic airways. Then you can get in foreign body. Typically, it produces fixed obstruction only. Then severe tracheal stenosis, or it can be seen in some bilateral vocal cord palsy, vocal cord paralysis. So some of the examples where you can get this kind of fixed obstruction. But please do remember, that why I told you these curves are very important, especially the shape of the curves are very important, is because whenever you have FE1 by FEC that is less than 0.7% and FEC is almost near normal or mildly reduced, surely you are telling it's an obstructive lung disease. But remember, you don't know whether it's an intrathoracic obstruction or, you don't know whether it's a large airways obstruction or small airways obstruction, because large airways obstruction as well as small airways obstruction will result in a, like obstructive PFT only. Your Tiffin index will be less than 0.7 and FVC will be most of the time near normal only. So which means you will definitely diagnose an obstructive lung disease, but you don't know whether it's a small airways disease or a large airways disease. If it's a small airway disease, typically that's why you have to see the shape of the curve, which is very important thing. The shape of the curve will be like typically scalloping kind of a curve. That's what you will see. But whereas in a large airways disease, typically you will see the flattening of the limbs, flattening of inspiratory or expiratory limbs of the curve or both the limbs if it's a fixer obstruction. So that is the reason why the shape of the curve is very important, because that is to differentiate between a large airway and a small airway obstruction. Remember, this curve is a typical OLD, means it's a small airways obstructive lung disease, not a large airway disease. Clear? This indicates a large airway. So this inspiratory flattening means extrathoracic large airways. This expiratory flattening means intrathoracic large airways. This fixed means extrathoracic or intrathoracic large airways. So typical diagnosed large airways versus small airways obstruction, you need to look at the curve. Then only you can find out. Just with the Tiffin index, you cannot differentiate between them. That is why identifying the shape of the curve is really, really important. So that's why I'm taking a lot of effort to tell this. But final say, I've drawn, you might ask me why I've drawn this. Final say, I'm telling now everything is normal. I'm putting a completely normal curve. I'm putting a completely normal curve like this. Everything is perfectly fine. But I am putting here it is inspiration and here it is expiration. Wow, what is this? I've just changed the inspiratory and expiratory limbs. If this kind of curves, if you see, this indicates the patient is on positive pressure ventilation. That is, the patient is on a mechanical ventilator. That's it. The mechanical ventilator flow volume loops will be inverted because here it is forced expiration. In normal, physiologically, when you are doing a flow volume loop in the laboratory, in a patient who is not ventilated, breathing normally by their own, you have a forced expiration and a forced inspiration. The forced expiration is the one that is forming this particular upper part of the curve. But here, in a ventilated patient who is intubated and given a positive pressure support, it is not forced expiration. It is typically a forced inspiration and a passive expiration. So this expiration will be usually passive and this inspiration will be forced. Whenever you see a reversed curve like this, please tell the patient is getting a PPV, positive pressure ventilation, or the patient is getting a mechanical ventilation. Clear? Alright. So these are the curves that you have to know. So I think I have made the curves as simple as possible. Right from the normal curve, you know the OLD and you know the severe OLD versus how to differentiate a mixed OLD versus RLD and the concept of pseudo restriction, and you know what is, how you get early stage of parenchymal RLD, or in some extra parenchymal RLDs also you will get the same curve, and how severe parenchymal RLD you will get this hamburger shaped curve, and what happens in severe obesity, what happens in extrathoracic obstruction, variable extrathoracic, variable intrathoracic large airways, or fixed large airways intrathoracic versus extrathoracic obstruction, and finally what will happen in a ventilated patient, what will be the curve nature. So all these things we have found out. So these are the different flow volume loops. I think you can get it easily. So now let us have a good comparison between restriction and obstructive lung disease. But before going into that, let us see what are the other pulmonary function like tests that you are going to use. The first one I am going to talk about is the DLCO. That's called single breath diffusion capacity of carbon monoxide. Single breath diffusion capacity of carbon monoxide. Remember, this is to test the diffusion. This is to test the diffusion across the barrier. This is a test to check the diffusion across the barrier. You might ask me why I am using carbon monoxide. You might ask me the fact why I am going to use the carbon monoxide. Because carbon monoxide is a diffusion limited gas. That's what your answer must be. Carbon monoxide is a diffusion limited gas. Whereas other gases like nitrous oxide, carbon dioxide, oxygen, all these things are perfusion limited gas. Perfusion limited gas. And one more reason why we use carbon monoxide, you know very well the carbon monoxide has 220 times higher affinity for hemoglobin. Increased affinity for hemoglobin, which means the moment it enters, crosses the diffusion barrier and goes into the blood, it is not going to come back by any means. It's going to bind to the RBC very strongly, hemoglobin, the RBC very strongly, and it's going to go into the circulation. And that too, you are using only a single breath. So this is what we refer to as something called a single breath diffusion lung capacity of carbon monoxide. So this is called DLCO. So what are the methods to assess DLCO? There are a lot of methods are there. The first one, the traditional method is, you call it as something called single breath diffusing capacity. Single breath diffusing capacity, which is supposed to be the gold standard. Gold standard even now. Second one, you have another technique called a steady state technique. Then you have another technique called rebreathing technique or rebreathing method. Fourth one, you have something called intra-breath method. And the fifth one, you also have something called a triple gas equation. Triple gas equation technique. So, but commonly followed and the most important, the gold standard is the single breath diffusion capacity of carbon monoxide. You need not worry about that, because some people might be worried, sir, I am actually inhaling carbon monoxide, that too for one breath, will it kill me? Obviously no. And the concentration what we are going to use is only 0.3%. So obviously in a metropolitan city, in evening traffic, if you walk in the road itself, you are exposed to 5 to 20% of carbon monoxide. Especially in cities like Delhi, you are going to get exposed to 20 to 25% of carbon monoxide. Seriously, in certain peak traffic conditions and all. So it is not, this 0.3% is not going to kill you. At the same time, this again single breath is definitely not going to kill you. So don't worry about that. Clear? So what are the things you are going to assess through DLCO? So let us construct a table. So we'll put a restrictive lung disease which affects DLCO, an obstructive lung disease that affects DLCO, and certain extra pulmonary causes itself that affect DLCO. So we'll put the DLCO on the y-axis here. So here let us see the condition where DLCO will be decreased. What are the conditions where the DLCO will be normal? And what are the conditions where DLCO will be increased? So let us see first. Restrictive lung disease, typical example I told you, where diffusion restriction. From the beginning I'm telling you from the physiology, basic physiology, diffusion limitation. One RLD that has diffusion limitation is ILD. We have been seeing this for so long. Diffusion limitation means only two things. One RLD is ILD, one OLD is emphysema. That's all. So I'm going to treat emphysema here. This is the first thing I have treated. In fact, this is the only OLD with diffusion limitation. Emphysema. Reduced DLCO. Apart from that, a lot of other causes can have, reduced DLCO. Like for example, patient might be having a pulmonary edema. Patient might be having a post-pneumonectomy. So anything you can write here. But ILD, emphysema, you should not forget. In other words, all these I can tell is nothing but I can put under a common group called parenchymal restriction. Parenchymal restriction. Anything that is related to the parenchymal lung disease, your DLCO will be reduced. RLD due to parenchymal disease. Similarly, OLD due to emphysema will have a reduced DLCO. And what are the extra pulmonary causes that have reduced DLCO? For example, reduced DLCO. DLCO is not only dependent on your, lung diseases. It can be affected by extra pulmonary also. First of all, how will you measure DLCO? So, for example, I'm going to take a canister that is containing carbon monoxide. Okay, this canister that is containing carbon monoxide, like a bottle you can take, and I'm going to inhale carbon monoxide, a single breath, and I'm going to exhale back. So see the amount of carbon monoxide in the canister now. If my diffusion of carbon monoxide is too much, the amount of carbon monoxide in the canister will be very less. If my carbon monoxide diffusion is very low, which means there will be not much change in the carbon monoxide in the canister. That's what I'm going to find out. So what are the other extra pulmonary causes that will reduce the DLCO? For example, conditions that have reduced pulmonary blood flow. Because the pulmonary blood flow is reduced very sluggish in the pulmonary circulation, the amount of carbon monoxide that is going to move into the circulation is very less because of reduced pulmonary blood flow. Typically, this happens in pulmonary hypertension. Anything that causes pulmonary hypertension, for example, I can get in a pulmonary embolism, or I can get in a condition like portopulmonary hypertension. So in any of these conditions, you can, anything that causes pulmonary hypertension, or anything that produces something called a right to left shunt. Typical example is Eisenmenger syndrome, right to left shunt. Clear? Or anything that's cyanotic congenital heart disease. Again, it's an example of a right to left shunt. So they are going to have whenever you have a reduced pulmonary blood flow, you are going to have a reduced DLCO. Next thing, severe anemia. Severe anemia. Obviously, oxygen carrying capacity is less because of low hemoglobin, which means the carbon monoxide carrying capacity is also less. So, severe anemia. Or if the patient is having very high levels of carboxyhemoglobin already circulating, example is smokers. Carboxyhemoglobin. Because already there is so much of carboxyhemoglobin, the movement of carbon monoxide will be less because already so much of carbon monoxide is circulating in the blood. Clear? So again, reduce the pulmonary blood flow, maybe, physiologically speaking, standing position and all, that and all is absolutely nonsensical, I'm not going to tell. What are the conditions where you can have a normal DLCO, but you can have a restricted lung disease? Yes, definitely possible, especially when you have a extraparenchymal restriction. Extraparenchymal restriction. So what you call by extraparenchymal restriction? Whenever you call the name extraparenchymal restriction, it means I'm going to deal with neuromuscular disorders. Neuromuscular disorders, or it might be due to pleural disorders, or it might be due to skeletal problems like kyphoscoliosis, which means a neuromuscular disorder or a like pleural disorder or skeletal disorder is not a parenchymal disease. It is an extraparenchymal disease that is preventing the movement of the lung properly. Because of that, you are having a restriction. FVC is low, but DLC was not related to the movement of the lung. It is a diffusion of the oxygen, carbon monoxide. Here the lung barrier and all is normal only, so diffusion of the carbon monoxide will be normal in this disease. There is no change in the diffusion of carbon monoxide. Okay, what is the OLD that can have a normal DLCO? Typically, you will see in other OLDs. All the other obstructive lung diseases will have normal only. What are the other obstructive lung diseases you can tell that can have a normal DLCO, like your chronic bronchitis, apart from emphysema, everything. Chronic bronchitis, cystic fibrosis, bronchiectasis, bronchial asthma, all these things are going to have a normal DLC only, because these are the other classic OLDs apart from emphysema, obstructive lung disease. What are extrapulmonary causes? I don't know any extrapulmonary causes. I can't tell any extrapulmonary causes with a normal DLCO. Okay. So what are the RLDs that will have increased DLCO? Remember, whenever RLD is having increased DLCO means it's a spurious cause. What do you mean by spurious? Spurious means actually the diffusion actually is less, but a DLCO alone is increased. How is it possible? Typically, this happens in a condition called diffuse alveolar hemorrhage, DAH. What happens in a diffuse alveolar hemorrhage? You have an alveoli and there is lot of blood that is staying within the alveoli, which means when you take carbon monoxide in, this carbon monoxide molecules inside, they will be trapped within the blood that contains hemoglobin that is seen in the alveoli only. Actually, this carbon monoxide molecule is actually not diffusing into the barrier at all. But since there is a lot of blood in the alveoli, spuriously your carbon monoxide will be trapped by this blood and it appears as if the carbon monoxide is diffusing a lot. That doesn't happen. So diffuse alveolar hemorrhage is spurious cause of spuriously elevated DLCO. Typical example you will get in exam is a Goodpasture syndrome, but you can get in any condition that produces diffuse alveolar hemorrhage, any vasculitis, including SLE. If you have diffuse alveolar hemorrhage, you are going to get this picture. What is the condition that can have increased DLCO but an obstructive lung disease? Rarely you might get this in a chronic bronchitis or a bronchial asthma, maybe because of hyperinflation. Chronic bronchitis and bronchial asthma, but don't tell. Usually they'll have a normal DLCO only. What are the conditions where you might get the extrapulmonary cause with increased DLCO? Increased pulmonary blood flow. So what are the conditions which can have increased pulmonary blood flow? Typically this can happen in patients who are having left to right shunts, left-right cardiac shunts, or patients who are exercising because of increased pulmonary blood flow. At the same time, it can also happen in patients with very mild heart failure because amount of blood in the pulmonary circulation will be more. So remember, if in severe heart failure, there will be congestion, interstitial edema, because of the DLCO will be reduced. But in a very mild heart failure where there is no interstitial edema, no exudation of the fluid, but there is pulmonary venous congestion alone a little bit, so that blood will be more in the pulmonary circulation, so that carbon monoxide may be trapped more. So mild heart failure can cause this. At the same time, it can happen in polycythemia. That's it. Supine position and all is nonsensical. I'm not going to tell that. So polycythemia is a very important cause. So this is how you classify DLCO causes. RLD with increased normal or reduced DLCO, OLD with increased normal or reduced DLCO, and similarly extrapulmonary causes with increased or decreased DLCO. All these things are very important causes and very important table to understand. And other things that you can try as a test of respiratory muscle function, a test of pulmonary function is, for example, second thing I'm going to talk is about the bronchoprovocative testing. Bronchoprovocative testing. So what do you mean by this bronchoprovocative testing? What's going to happen here? So remember, this bronchoprovocative testing has a very high negative predictive value. That's what I will tell first. It has a very high negative predictive value. Typically, it is used for testing for bronchial asthma. In fact, since it has a very high negative predictive value, I can use this test to rule out bronchial asthma rather than confirming bronchial asthma. What I'm going to give. So typically, I'm going to use something called a methacholine. Typically, I'm going to use this thing called methacholine. So what is the principle of using this methacholine in bronchial asthma? I told you bronchial asthma is characterized by very important thing. The first thing is reversibility. First thing is reversibility. Why this point is very important in bronchial asthma? Because I'll discuss in detail about this thing in bronchial asthma, but you have to understand the PFT normalization. Among all the obstructive lung diseases, the only obstructive lung disease that can normalize the PFT completely is your bronchial asthma. So reversibility. Clear? Complete PFT normalization. And there is also one more definition of reversibility is there. Suppose you give a bronchodilator testing. When you give a bronchodilator testing, if your FEV1 improves by at least 12% from the baseline, or if FEV1 improves by at least 200 ml by absolute value, this is also one of the signs of reversibility. And again, this things and all goes more in favor of bronchial asthma than COPD. Remember, but what is the most important thing that will tell you it's surely a bronchial asthma? It is PFT normalization. Remember, it is the only disease that shows complete normalization of the PFT spontaneously itself. Very, very important point. At the same time, PFT normalization also, this PFT reversibility that with bronchodilator challenge also is very important. You can use a bronchodilator or you can use a steroid challenge also, where FEV1 increased by absolute value of 200 ml or relatively by 12% from the baseline also relatively goes more towards the bronchial asthma. Remember, if the PFT normalizes with bronchodilator or the PFT completely normalizes spontaneously, means the only one OLD you can diagnose is bronchial asthma. Only. There is no other disease. At least this as a diagnosis of COPD alternatively. So anyway, you can remember two things. PFT normalization with or without bronchodilator, or after giving a bronchodilator challenge, FEV1 increased by 12% from the baseline, or absolute increase by 200 ml. Definitely in exam at least you're going to diagnose a bronchial asthma. So this is what we refer to as reversibility. And second thing, bronchial asthma is going to exhibit is something called a diurnal variation. This I will tell you during the bronchial asthma chapter. So diurnal variation, typically you are going to find out PEFR and find out the diurnal variation. Clear? And third thing the bronchial asthma is going to show is something called bronchial hyperresponsiveness. Bronchial hyperresponsiveness. Remember, these are not very important, but still bronchial hyperresponsiveness is a very important feature of a bronchial asthma, which means they go for bronchoconstriction with exercise, they go for bronchoconstriction with agents like methacholine very easily. So this bronchial hyperresponsiveness is one of the very important pathophysical aspects of bronchial asthma. It can be seen in certain patients with COPD, but anyway, at least in exam you answer it's a bronchial asthma. So what you are trying to do in bronchoprovocative testing by giving methacholine is to find out the bronchial hyperresponsiveness in bronchial asthma. You are going to actually trying to find out the bronchial hyperresponsiveness. How? When you give methacholine, what are you going to expect? So if the FEV1 declines by at least 20% of or more with 16 to 25 milligram per ml of methacholine. So this is the perfect definition of bronchial hyperresponsiveness. This is the perfect definition of bronchial hyperresponsiveness. Clear? When you are going to give 16 to 25 milligram per ml of methacholine, and by giving that, if you are achieving a decline FEV1 by at least 20% or more, it confirms bronchial hyperresponsiveness. Remember, again there is a pitfall here. When you prove it's a bronchial hyperresponsiveness, it doesn't tell you it's surely bronchial asthma, because I told you already there are some COPD cases where still they exhibit bronchial hyperresponsiveness. But if the test is negative, which means you don't have this FEV1 decline by 20% with 16-25 milligram per ml of methacholine, it rules out bronchial asthma. That's why I told you this test is more of a ruling test rather than a confirming test. So this is what is very important to understand. This is bronchoprovocative testing. Then next thing, you have something called a test of respiratory muscle function. Test of a respiratory muscle function. So what are the tests of respiratory muscle function you have? So you have something called maximal inspiratory pressure, and you have something called a maximal expiratory pressure. So what is the normal pressure? Normal maximal inspiratory pressure is always negative. When you are taking in, you are getting a negative pressure. So maximal inspiratory pressure is going to be somewhere between minus 100 to minus 140 centimeters of water. Minus 100 to minus 140 centimeters of water. And the maximal normal expiratory pressure is always positive in a normal patient. So plus 95 to plus 140 centimeters of water. Centimeters of water. So this is the maximal inspiratory pressure and maximal expiratory pressure. Remember, whenever the maximal inspiratory pressure is not sufficiently negative, or whenever the maximal inspiratory pressure, maximal inspiratory pressure is not sufficiently negative, or the maximal expiratory pressure is not sufficiently positive, it indicates a poor respiratory muscle function. Clear? So in neuromuscular paralysis, it will be useful. So there is indications for intubation. Even in a patient who is having neuromuscular paralysis, you have something called indication for intubation. Suppose if the maximal inspiratory pressure, if it is more than minus 30 millimeters of mercury, which means you are not able to reach minus 30. It's more than that, which means minus 20 or minus 10. Definitely it's an indication for intubation. And similarly, if the maximal expiratory pressure is less than 40 centimeters, sorry, I'm writing millimeters of water. Let me put centimeters of water. Similarly, if the maximal expiratory pressure is less than 40 centimeters of water, which means you are not sufficiently achieving that maximal expiratory pressure, and again it's an indication for intubation. So typically, for example, in a patient like Guillain-Barré syndrome, where they have neuromuscular paralysis, we have a rule called 20, 30, 40 rule. 20 means if vital capacity is less than 20 ml per kilogram, or if it is less than 1.5 liter as a whole, as a total. Second, if the maximal inspiratory pressure is more than minus 30, or the maximal expiratory pressure is less than 40 centimeters of water. This is called 20, 30, 40 rule, and this is an indication for if any of this thing is there, it indicates impending respiratory failure, and you have to intubate the patient immediately, which means it's a impending respiratory failure due to neuromuscular paralysis. The patient is going to die of respiratory failure, so you have to definitely intubate these patients. So this is one important respiratory muscle function. And then finally, one miscellaneous respiratory muscle, pulmonary function you have is something called 6-minute walking test, otherwise called a shuttle walking test. 6-minute walking test, where the patient will be asked to walk for 6 minutes. Lot of criteria are applicable, but anyway, just to understand, I'm telling 6-minute walking test is the test of functional exercise capacity of the patient. Functional exercise capacity of the patient. Typically, you can use to this 6-minute walking test, and this functional exercise capacity is important for assessing certain diseases, morbidity and mortality. You can assess the morbidity and mortality of certain diseases like COPD. This is the most important. COPD, then pulmonary hypertension, heart failure, and all these things. So, and again, for transplant evaluation, especially for lung transplant evaluation. So for lung transplant evaluation, in all these conditions, the 6-minute walking test is a very, very, very important test. But in exam, they will be asking you the COPD only. Why? Because in COPD, you have a prognostic index called BORD index. And before lung transplantation, also the 6-minute walking test is mandatory. A lot of tests you do, but one of the important tests is 6-minute walking test. What do you mean by BORD index? B stands for BMI, O stands for obstruction. O stands for obstruction, which is usually indicated by FEV1, and D stands for dyspnea, given by modified MRC scale, which I'll explain you in detail in COPD section, and E stands for exercise capacity, and this is assessed by 6-minute walking test only. So BORD is a very important prognostic index for COPD, in that E stands for the exercise capacity, which is assessed using 6-minute walking test. That's why this is very important. And pre-lung transplant evaluation also very important. This is also a question in exam, where you assess the 6-minute walking test. And final nail in the coffin, you have to know that COPD, especially your emphysema and chronic bronchitis, is best assessed by FEV1 and monitored by FEV1. Assessed and monitored by, because the disease monitoring is through FEV1 predominantly, because your gold criteria, your like COPD prognostic tools, everything use FEV1. Similarly, in bronchial asthma, the most important tool that you are going to use is PFR than FEV1. So in COPD, FEV1 is more important. In bronchial asthma, PFR is very important compared to FEV1. Clear? So these are two things that are for monitoring purpose, I'm telling. Again, for disease monitoring purpose, use PFR here. So that is why these two also is very important to understand. Clear? So now let us see the final things. Only two more things are there which we are going to discuss. What are the differences between an obstructive lung disease and a restrictive lung disease? Clear? So let us see the etiology first. Etiology wise, you have COPD and the classic obstructive conditions like bronchial asthma. Remember, bronchial asthma, only in acute settings they behave like an OLD. Remember, once the acute attack is over, bronchial asthma patients are like you and me, normal patients only. They don't have any finding in the PFT. That's why I told you reversibility, which means a complete normalization of the PFT can happen only in a bronchial asthma patient, which means without an acute attack. I mean, I'm not telling all the patients. A lot of patients will have continuous symptoms depending on the stage of the bronchial, depending on the severity of the bronchial asthma. But many of the patients that are seen in the community may have a completely normal PFT once the acute attack is over. So we cannot diagnose bronchial asthma. We cannot rule out a bronchial asthma with the absence of these. You cannot rule out a bronchial asthma by having a normal PFT, not like that. They have a normal PFT, many patients. After the acute attack, once the acute attack is over, and they may not have any V's at all, any signs at all, they might be completely normal like you and me once the acute attack is over. So absence of V's or normal PFT is not a criteria to rule out bronchial asthma. Please be very careful. Okay, bronchial asthma during acute attack. Then you have a cystic fibrosis. Then you have a bronchiectasis. COPD means you include both emphysema and chronic bronchitis. So these are the typical OLDs. RLDs I can put under intrinsic and extrinsic causes. Intrinsic means intrapulmonary restriction. Extrinsic means I can put under extrapulmonary restriction. Intrapulmonary means anything that related to parenchymal disease, especially ILD, anything related to the interstitium and the parenchymal disease, like sarcoidosis, pneumonia, everything will come under here. Extraparenchymal means bone disorders like kyphoscoliosis, pleural disorders like pleural thickening, effusion, pneumothorax, pleural fibrosis, fibrothorax and all, and neuromuscular weakness. These things will come under extrapulmonary. Typically, I need this neuromuscular and bone only. That is very important. Pleural, we have a lot of evidence. It's very easy. Nobody is going to do a PFT in a pleural disorder. It's absolute rubbish. Anyway, even though it's a theoretical cause. Then let us see the findings in spirometry and other areas. So what will happen in FEV1? I told you FEV1 will be dramatically decreased in obstructive lung disease, where it will be decreased in RLD, but not that much. FVC will be usually normal, or only mild decrease will be there, but whereas here there will be a dramatic decrease. Very important. So what will be the FE1 by FVC, Teffeny index? We have seen this many times. Where here it will be, in obstructive lung disease it will be severely decreased and it will be less than 0.7. Whereas in a restrictive lung disease it can be normal or even increased, which means it will be more than 0.7. That's the most important point. And what about the total lung capacity? Total lung capacity, definitely it will be increased in case of an obstructive lung disease. This increase in the total lung capacity is what we refer to as hyperinflation. That's the definition. And here it will be definitely decreased, no doubt. In any form of RLD, it will be decreased. But remember, residual volume, definitely in OLD, it will be increased. This increase in residual volume in OLD is what we refer to as something called air trapping. And in a restrictive lung disease, it is variable. It is variable in a restrictive lung disease. Why? Remember, there are two types of causes. In intrinsic causes, your residual volume may be decreased because of the shrinking of the lung itself. In extrinsic, extra parenchymal causes, your residual volume may be normal or even increased. This is a very important point. So, best example is taken neuromuscular disease, neuromuscular paralysis. What happens in neuromuscular paralysis? I am not able to move my diaphragm. So, what do you mean by residual volume? The amount of air that I cannot exhale at all. That is residual volume. No matter how much I would try, amount of air that I cannot exhale is what you define as residual volume. In a patient who is having neuromuscular paralysis, what will be the amount of air that I cannot exhale? It will be increased only. It can be normal or even increased in neuromuscular paralysis. That is why I am telling it is variable. That is why in extrinsic cause, extra parenchymal cause, it will increase or it can be even normal. Because in a neuromuscular paralysis, the amount of air that I cannot exhale at all will actually, that proportion will increase. It's a very important thing. Clear? So, let us see what happens in a normal patient versus an RLD. Let us assume this is a normal patient. This is a patient who is having an RLD, typically a like parenchymal RLD. So, let us assume this is a parenchymal RLD. This is a patient with an RLD who is showing a similar picture but having an extra parenchymal RLD. See very clearly here. So, let us assume this is the residual volume and this is the vital capacity in a normal patient. So, here what is happening in a parenchymal RLD, everything is proportionately decreasing. Here the residual volume is decreased definitely. Input like this. Here the residual volume is decreased and the vital capacity is also decreased. You can see both are decreased proportionately. There is no doubt. But in extra parenchymal RLD, the vital capacity decrease will be so low, which means they cannot take air at all because of the severe neuromuscular weakness, and the residual volume may appear even increased or even normal. You can see here the residual volume compared to the normal, it's appear to be increased or even it can be normal. That is because even though the actual total lung capacity is decreased in both parenchymal as well as extra parenchymal RLD, the residual volume may appear increased or normal. That is because the proportion of air that they can exhale is actually very less, which means the proportion of air that stays in the lungs without getting exhaled at all is more, and that is what you call as residual volume. Understood? Okay, this is residual volume. Then you have resistance to airflow. Resistance airflow is very high here. Typically, it is supposed to be normal unless until you have a mixed OLD versus RLD. Then complaints of the lung. Complaints of the lung. It depends on whether it's a static complaints or a dynamic complaints. For example, let us say it's a static complaints. I mean, two disorders. Let us see other OLDs. I mean, this is something little bit confusing. Other OLDs, and let us see what will happen in emphysema. Other OLDs, what will happen in static complaints and dynamic complaints. So, other OLDs, we'll see the static complaints first. Static complaints will be normal in other OLDs, whereas the dynamic complaints may be decreased. Clear? Why the dynamic complaints may be decreased? That is because of the dynamic complaints is a measure of both airway resistance as well as the static complaints. Since airway resistance is high, the dynamic complaints is low. Whereas in emphysema, the static complaints is actually increased. That's why I told you, because the loss of elastance inversely proportional. But the dynamic complaints may be decreased. That is because of the, when you're taking airway resistance into account, because emphysema patients are tend to have a severe increase in the airway resistance. So this is very important to understand. But whenever they ask you, remember, it always means static complaints only. So that is what you have to answer. Always it means static complaints. Emphysema means increased static complaints. When they ask just complaints, go for static complaints for the answer, please. Here again you have extrinsic versus intrinsic, which means intraparenchymal versus extraparenchymal. Intraparenchymal I am going to call intrinsic, extraparenchymal I am going to call extrinsic. So what will be the static complaints? It will be definitely reduced, there is no doubt. And the dynamic complaints also definitely it will be reduced because the static itself is reduced. In extrinsic disease, static complaints will be reduced, whereas the dynamic complaints can be relatively normal. So this is a very important point to understand. So in general, if they ask you complaints in RLD, always tell it is decreased. Very important. I mean, they won't ask this for knowledge I'm giving, but anyways, if they ask you emphysema complaints, tell it's increased. If they ask you RLD complaints, it's decreased. That's all. Keep it simple in exam. It's all about keeping simple. So, what about the DLCO? I didn't tell anything about the DLCO at all here. So, DLCO, if you ask me, in obstructive lung disease, typically in emphysema, only DLCO will be decreased. But in other obstructive lung diseases, DLCO will be normal, or there can be a mild increase, but typically, like what we see in real practice, normal DLCO. So, what about your RLD? Intrinsic RLD definitely reduced, but remember, exception, it can be spuriously elevated in diffuse alveolar hemorrhage. Extrinsic causes, extraparenchymal causes, typically you have a normal DLCO. There won't be any alteration in the DLCO. And you know the flow volume loops, typically. Small airways, obstructive lung disease, you are going to have a scalloping. Large airways, obstructive lung disease, you are going to have an inspiratory or expiratory flattening, or both flattening if it's a fixed obstruction. RLD, you will see, like decrease in size of the entire curve with very low FVC, or you will see a hamburger shape in case of a severe parenchymal RLD, which can actually elongate the curve, and you can see a hamburger shape with severe decline in FVC with increase in PEFR, in fact. So, that and all we have discussed already. So, we have seen all these things. The final thing what we are going to see is on the flow chart. The final thing I am going to give is on the flow chart. This is the final flow chart I am going to use, which you can see in 5 minutes max. So, the step number 1, I am going to see something called FE1 by FVC. That is the step number 1 I am going to see. So, whether it is less than 0.7 or more than 0.7. Whenever it is less than 0.7, it is suggestive of an obstructive lung disease. I told you already. So, when it is suggestive of an obstructive lung disease, next step is see the FVC. This is step number 2. When you see the FVC, it is less than 0.8 or more than 0.8. That's what you're going to see. Remember, one trick I will tell you here, only the Tiffany index has a 0.7% as a cutoff. Less than 70% or more than 70%. Every other value, you will be having 80% as a cutoff. That is 0.8%. That's it. That's the most important thing you have to understand. Only Tiffany index is 70% is the cutoff for normal and abnormal. Every other single value, you are going to take 80% only. Be it TLC, be it residual volume, be it DLCO, be it FVC, doesn't matter. Every other value apart from FE1 by FVC is, you are going to take 80% as the cutoff. So, less than 0.8 or more than 0.8, which means more than 0.8 means it's normal. Definitely it confirms it's an obstructive lung disease. Confirms it's an obstructive lung disease. But remember, FVC less than 0.8 with the Tiffany index of less than 0.7 means there are two possibilities. Either it could be a very severe OLD with pseudo restriction, I told you already, versus it could be a mixed restricted lung disease and an obstructive lung disease. Mixed RLD was plus obstructive lung disease. So, I told you how to differentiate this, put into a body box and find out the TLC. When you do the TLC, again whether it is less than 0.8 or more than 0.8. I told you if the TLC is high, more than 80%, it's hyperinflation, which means it's suggestive of a severe OLD with pseudo restriction, very likely. And this usually happens in a disease called emphysema. If it's less than 0.8, usually it indicates a mixed RLD and an OLD. Clear? Suppose I told you it confirms OLD, isn't it? So, now you have to find out what is the OLD. Give bronchodilator challenge. Give bronchodilator challenge and see whether the PFT normalizes or not. I am not telling the reversibility. See whether the PFT normalizes or not. If the PFT normalizes with bronchodilator, yes means definitely only one diagnosed possible bronchial asthma, because COPD by definition itself is a fixed if it cannot normalize. If it doesn't normalize, then probably you are dealing with either a bronchial asthma with a variant with the overlap with COPD called chronic asthmatic bronchitis, or you are dealing with the COPD. So, do a DLCO. In this condition, if DLCO is decreased, that is less than 0.8, DLCO is less than 0.8, decreased, or DLCO is normal, more than 0.8. If DLCO is decreased, the only obstructive lung disease that has reduced DLCO is emphysema. Then if DLCO is more than 0.8, it indicates either bronchial asthma or a chronic bronchitis. Many times it will be an overlap, like chronic asthmatic bronchitis they will call. Anyways, if it doesn't, if there is no normalization of the PFT. Anyway, fine. So this is how you make a diagnosis. Now more than 0.7. It could be normal or it could be a patient of a respiratory lung disease. So how you are going to assess this? See the FVC. So FVC can be less than 0.8, which means it's low, it's decreased, or FVC can be more than 0.8. If FVC is less than 0.8, it is definitely a confirmed RLD only. There's no doubt about that. Low FVC with a normal FA1B FVC confirms it's an RLD. Now we have to find out what is the RLD. So see the DLCO. So see the DLCO, if it is less than 0.8 or if it is more than 0.8. If it is less than 0.8, it is likely to be a parenchymal RLD. Parenchymal RLD, best example you can call it as ILD, interstitial lung disease. But remember, be very spurious. In this diffuse alveolar hemorrhage, DLCO can well be more than 0.8, even if it can be increased. This is the one parenchymal RLD with a high DLCO. Be aware of this. If DLCO is more than 0.8, it is very likely to be an extra parenchymal RLD. The moment I call extra parenchymal RLD, neuromuscular versus bone, how will you find out? Do MIP and MEP, that is maximum respiratory pressure and maximum expiratory pressure. These are tests of muscle function, respiratory muscle function. If it is decreased or if it is normal. If it is decreased, I am going to call it's a neuromuscular cause. If it's normal, I can tell it's a bone or pleural cause. Typically a bone cause, pectus excavatum, pectus carinatum, kyphus collius, all these things will have normal MIP and MEP only. Okay. Now FVC is normal. FVC is more than 0.8. So I am also telling that all other lung volumes are normal. All lung volumes are normal, which means every single lung volume is normal. There is no abnormality at all. All lung volumes normal, and FVC is normal, and FE1 by FVC is also normal. There's no doubt about that. What are you going to see? In this condition, see the DLCO. DLCO may be less than more than 0.8. More than 0.8, or DLCO can be less than 0.8. So whenever DLCO is less than 0.8, still it could be a bronchial asthma versus a normal patient. I told you bronchial asthma patients may have a completely normal PFT. Only during the time of acute attack may have a abnormal PFT, but when you test during normal states, when you test during resting state, they have a normal PFT. So whenever you have confusion like this, completely normal lung volumes, everything is normal, still you suspect a bronchial asthma, this is the best place where you can use something called this bronchoprovocative testing. This is the best indication for this methacholine challenge, a suspected bronchial asthma patient with a completely normal PFT. So if methacholine challenge is positive or negative. If methacholine challenge is negative, definitely you are going to rule out bronchial asthma. There is no possibility of bronchial asthma, which means it's a normal patient for sure. If methacholine challenge is positive, I cannot surely tell it's a bronchial asthma, it's a likely bronchial asthma. That's it. Likely bronchial asthma. Still, many normal patients also may show bronchial hyperresponsiveness with methacholine. They may not have bronchial asthma at all. So, likely bronchial asthma, that's all. If DLC was less than 0.8, something is wrong. I'm going to think about extra pulmonary causes. Extra pulmonary causes. Extra pulmonary causes. Or it could be a very early ILD. I told you one of the important classical problems in interstitial lung disease we have been discussing for a long time from pulmonary basics is diffusion limitation. So, very early stages of ILD can have purely diffusion limitation alone without any other problem. Only diffusion limitation can be there. So, that is why this point is very important to understand. Or it could be some extra pulmonary causes where the patient can have pulmonary, conditions that produce reduced pulmonary blood flow. Typically, that's what they will ask. For example, patient may have a pulmonary hypertension, pulmonary embolism, or patient may have a right to left shunt, cardiac shunt, or severe anemia. Clear? So, anything can be there. But anyway, usually in exam, they will expect this pulmonary hypertension only. Remember, whenever isolated decline in DLCO is there, in exam, usually whenever there is an isolated decline in DLCO and all the other lung volumes are normal, everything is normal, always think about pulmonary hypertension in exam. Usually they will give This in association with CREST syndrome, very common AIMS question. They'll give an association with CREST syndrome where pulmonary hypertension is very, very common there, pulmonary arterial hypertension. So, like this is how you are going to assess your PFT. It's a very, very simple algorithm which I have explained you in detail for the last 1.5 hours. So very easy to understand. So this is the easy thing that you have to note about the pulmonary function testing. I have given in detail about the pulmonary function testing. I also told you what to answer in exams also. With this, we are completing the pulmonary function testing. In the next section, we'll be discussing in more of control of breathing, and probably after that we'll be discussing on the pneumonia part.